intermediate acting. I'm going to put my syringe in here, air into air, right? So that syringe isn't touching any of the fluid that's down in that vial. I put my air then down into it. I withdraw my needle, okay? Now I'm going to draw up 14 units of air for my short-acting insulin. I'm going to go into that, inject down into it, okay? And then I'm going to immediately flip it up and draw up my 14 units. Now, when you're drawing up this, you can pull up more than you need. You can give some good flicks, really get those air bubbles out. Even pretty small air bubbles can displace a fair amount of this insulin. Even 15 or 14 units you can see is really not that much in that syringe. So if you had a huge air bubble in there, you could actually lose a couple of units of insulin. Yes, it's going sub-Q, so a little air bubble isn't going to hurt your patient. So here it's really more about displacing the medication and making sure you're giving the appropriate medicine. So if you need to, flick it good, you can go back into this vial. It's fine, whatever you need to do to get those 14 units up. I like to sometimes pull really quickly on the bottom of my syringe. It creates a little turbulence in there. You'll see a whole bunch of bubbles kind of whirl up like that, and then you can, usually they're all at the top, and you can push them out, okay? So I have my 14 units then. I need to do some checking of this, right? So I have my 14 units. I'm looking at my regular insulin. I'm doing another check. I mean, in all reality, we should check both of these insulins 3 times, right? That's really challenging to do because we're just standing here looking, right? But you need to check, you need to draw up, you need to check again that we really have this correct dose of insulin, right? You have regular insulin, 14 units, all right? You'll see in some places, like I said, we kind of check both 3 times. Okay, I have regular insulin, 14 units. I really know that that's what I have in this syringe. Okay. Now I'm going to go to my NPH insulin. Some resources are now saying that you should insert your needle into the core of this insulin vial at a 45-degree angle instead of 90 degrees. The research is showing that going down like this kind of cores the little rubber stopper a little bit, and we actually might get some rubber into the tip of the needle. And so what you do then is you just look at your needle, bevel up, you go in at 45, right, still into the middle, and as soon as you're in, you flip it up like that. Did you guys see me do that? And so when you're going into these vials, that's how we should be piercing the vials. Be careful, these needles are really, really, really small. If you bend them, the worst thing, you just get another one and start over. It's not the end of the world. It happens in practice all the time. So now I'm going to flip this up and I'm going to draw up my 38 units, which is how many units total? 52. So I'm not drawing to 38 on here, right? I'm drawing to 52 on here. So don't make that mistake in your comp. You got to really draw up to the 52 mark. And you can't go back and forth now that you're in this intermediate acting, because you'll push regular insulin back into this vial. So you have to be precise in your withdrawing of this medication. You pull down exactly to that 52 mark. So make sure that you really know where that 52 mark is. So I'm at 50, 51, 52. Okay, so how slowly I went there at the end to make sure that I had the correct dosage of insulin. Okay, I'm going to do some more checking here. I have my NPH insulin. I had 14 units of that. So now I somewhat have to assume, right, that I now have 38 units of NPH in there because my total is 52, right? So you're going to check that. You're really doing 3 checks here in that prepare section, because how else can you really do that? I'm going to recap again. Scoop. These also sit nice like that. I think this is a nice method for recapping. Just make sure that this safety is headed into the right area. Again, this is a big place you could bend that needle at. Okay, so I have this. I need then to label my syringe here to make sure that I have the appropriate dosage. Who's got a pen for me? Thank you. Patient's name. I'll actually put on here 14 units regular, 38 units NPH. Okay, prepared date, time, expires date, time, all of that good stuff goes on this syringe here. Okay. I need to keep both of these with me because I need to scan both of those vials. All right. So I have my syringe. I'm putting my label down here so I can clearly see my units are appropriate. And now, per really policy, I've really kind of just done my 2 outside checks because I need to still go in and scan my patient and do another check once I've scanned my patient. So you can see how those 3 checks get a little convoluted with these medications. So don't be afraid to over check these, right? You draw up your regular, check 3 times. I draw up my NPH, check 3 times. I know it seems somewhat redundant, but we are giving a high risk medication here. So don't be afraid to really do some over checking while you're drawing that up. And then when we go into the patient's room, we're still doing another full check there, but we've already drawn them up. So it's kind of like those checks are a little bit different with this scenario. Okay, does that make sense? Good. So then I would go into my patient's room, and again, I have another nurse present during this time who's seen what I've drawn up. She doesn't necessarily need to maybe go into the patient's room with me to see me administer it, but she needed to see me draw it up and check it 3 times to make sure that it's the appropriate dose. They then sign off on the MAR that they've checked it. That window usually pops up after you scan your meds, it pops up. So a lot of times you'll see the nurses scanning the meds out in the hallway for this one. Like they've gone in, they verified their patient, scanned their patient, they come back to the door, scan their med, the other nurse kind of comes up, does their check, they walk back in the room to administer this to their patient. Okay, so when we go then into the patient's room, we're gonna scan their bracelet, we're gonna talk to them, see how they're feeling. You might do some education there about signs or symptoms of hypoglycemia, see where their lunch tray is, make sure you understand what their blood glucose level is. It doesn't say anything on here about having to give a certain dose based on the blood glucose number, but you still need to know what their blood glucose level is because you're about to give a short-acting insulin, and so that this right here truly is a nutritional dose, right? It's based for lunch and dinner, or breakfast and dinner here on this MAR, okay? So you need to understand what that blood glucose level is. So I scan my patient, I click in the boxes here, I scan my medication, I click in the next box, I scan my next medication, and I really want you guys to stop here and make sure, okay, I have my regular insulin, yep, I scanned it on my MAR. Remember, I'm checking to this MAR down here, but in comp, really, our MAR's here on this. I have my regular insulin. I drew up 14 units. I know that because I checked it 3 times before I added the NPH. But I'm just doing another check that I really have the right insulin here. Now I have my NPH. Okay, I have a total of 52 units, which mean I gave 38 units of that. I'm good to go. Okay, and I'm going to administer it. So how are we going to administer sub-Q? Find that site that we talked about. Gloves on, right? So lots of hand hygiene before we go to give this when we go into the patient's room. Gloves on. Find a little spot. I like to find that little spot. Alcohol. I like to leave my alcohol then right there on the patient. It helps me to remember where I alcoholed because you're going to probably turn around then and pick up your syringe. You go back, you're like, where did I alcohol? I don't remember where I alcoholed. It's a little guide for you. Pinch up, remember, go in that 45 or 90 degree angle, inject that medication, pull out, put your safety up, put it in your sharps container, get rid of those gloves, do some hand hygiene, okay? Then you're gonna, of course, monitor your patient for signs and symptoms of hypoglycemia post-insulin administration. So you're gonna wanna come back in and check on them at that 30-minute mark for that peak onset or the onset of the regular insulin, and then monitor them after their meal. Make sure they ate enough, make sure they didn't receive too much insulin, and that they're not feeling any of those signs and symptoms. Okay? So any questions about the checking, the actual giving of the insulin? Because I'm not going to do that for each one of these scenarios. Now we're just going to kind of talk through the different MARs and how we would prepare for those MARs. Okay? So your next MAR is Marty Moffitt. And so Marty Moffitt has Lantus or Glargine insulin, which is our long-acting insulin, and also needs some Lispro per sliding scale. And so that's, remember, a correctional dose of insulin. So here we certainly need to know what that blood glucose level is because we couldn't dose our insulin appropriately if we didn't know what that blood glucose level is. So the very first thing we need to do is get that blood glucose level. let's say our blood glucose level is 185. So if our blood glucose level is 185 at 7 a.m., what are we going to do in terms of giving insulin to this patient? 2 units of Lispro, and what else do they need?
8 units of Lantus.
8 units of Lantus. Can we mix those insulins?
No.
No. So this is going to be 2 separate syringes, 2 separate labels. And so here you can really do your 3 checks just as we've learned, because you got 2 separate syringes. Make sure that you're really checking right, because this is where we could get labels mixed up. We could be giving 8 units of regular insulin instead. So really do diligent checks here. So you're going to get your meds, you're going to pull them out, you're going to check them against your MAR, you're going to prepare them on that first check, you're going to check them again outside the room, you're going to go into your patient's room, check them a 3rd time, and administer them to your patient. So here, when we're just giving out of 1 vial, you're just going to scrub the hub, pull up the air in the syringe that you need, inject it into the vial, flip it up, draw up the one you need, put your label on it, be done with that one. I don't want to see 2 syringes here that don't have labels on it. So you're going to do 1, label it appropriately, set it to the side with the vial that you've drawn it up in, then go to your second one, draw it up, do your checks, make your label, and now you have both. That concludes your first check there. Then you still have to do check 2 and check 3. Okay? We cannot mix that long acting. So this is 2 separate syringes going into your patient. Yes, it's 2 pokes, but it is what it is. They're little tiny needles. You can give them in the same similar site, so you could give them in the same arm, just not exactly one on top of each other. So maybe one down here and one up a little bit farther, depending on how much sub-Q tissue they really have there. Okay. Any questions about that?
You said going in at 45. Is that just when you're mixing 2 different types?
Anytime you go into the insulin vials, you should go at that 45 and then flip right up to 90. Okay, good question. In the middle of these MARs, because that's how it got printed at the print shop, is this insulin general rules kind of here. So just review that. We've kind of, I think, already talked a little bit about this. Your peak times, your pre-mixed, IV. You don't have to give IV, but we know regular insulin is the only one we can give IV. So Kathy Devers is the next one. And Kathy Devers has multiple types of insulin. She has a sliding scale dose of Lispro, which is a correctional dose. She has Lispro 4 units, which is her nutritional dose. And then she has Glargine 12 units at bedtime, which is the long-acting insulin. Okay. So you might pull different cards here. Different times could really vary how this comp goes. But let's say we're doing the 8 a.m. administration. How are we going to give those 2 insulins?
Together in the same syringe.
Together in the same syringe, because it's the exact same insulin. So we just need to figure out, let's say the blood glucose is 232. How many units is that based on that? 4 units plus our nutritional dose of 4 units. So how many units of Lispro am I giving? 8 units. 1 syringe, 1 vial, same thing there. You're just going to draw up 8 units. You're only going to label it with 1. So I don't want to see 2 separate syringes here. We need to understand we can give those in the same syringe. Okay? You do your checks just as you would. 3 checks, standard practice. Prepare on the first check, label on the first check, second check outside the room, go in, scan your patient, do the 3rd check. Okay? Our last one then is Mary Gober, and Mary Gober only has 1 rapid-acting correctional dose to give. So there's only 1 insulin on her MAR. Maybe fingers crossed we all pull this one. I'm sure that's what you're all thinking right now, like, ooh, I want Mary Gober. So all you have to know is what your blood glucose is. There's really not much to get confused here. If you're doing your 3 checks, you'll know you got the right insulin. You give the dose based on what their blood sugar is. So this skill, while it's unique because we've never given insulin before, we've done a lot of pieces of this skill. All of the medication checking, the syringes, drawing up medications, giving sub-Qs and IMs. So really the only thing of this that is truly new is knowing which insulins can we mix, how do we dose based on a sliding scale, make sure we understand what that blood glucose level is, make sure we know and teach our patients signs and symptoms of hypoglycemia so that they can put that call light on if they start to feel that way. You know, you don't want to come in and just find